Good afternoon, everyone. Welcome to Chicago. Couple of things here. First of all, anytime you give a talk, the most important thing is to know your audience. I know exactly who my audience is. You guys want to pass the boards. And so I tried to make this talk as poignant as possible to specifically focus on that. I will try to highlight scenarios where there's pearls or highly testable information. If anyone wants to sort of talk more about pulmonary hypertension in general, I love doing so. We can do it off to the side. But for the next 30 or so minutes, I did my best to try to really focus on what I actually think are going to be the areas that are highly testable. The other thing is this is actually the only talk I'm going to be giving to you guys as part of this board review course. So I made sure that it's really awesome. All right, so let's get started. Oh, and the other thing is, the audience response questions, as you know, have sort of had some snafus. What I did is I put a question here at the beginning and a question at the end. I had it all set up to see if you kind of didn't know it at the beginning, but then learned something during the talk. But I think this will still be okay. So let's walk through the first question together, kind of like you did with Dr. Rogers. 48-year-old woman was diagnosed with idiopathic pulmonary arterial hypertension 6 years ago. She was initially treated with oral targeted PAH therapy, but 3 years ago, she was transitioned to IV epoprostenol because of worsening symptoms. Trade name Flolan, okay? But epoprostenol is the one you should know. Unfortunately, despite initial improvements, her condition has again deteriorated. She's now seeking an opinion about advanced treatment options. Her echo reveals severe RV dysfunction. So you repeat a right heart cath, which reveals an RA pressure is 24, her PA pressure is 92/40 with a mean of 58, her wedge is 12, cardiac output of 3.8, index of 1.9. She's tachycardic, her blood pressure is 92/68, her oxygen saturation on room air is 94%. Okay, so which of the following is correct? I guess we can do a show of hands. Intravenous epoprostenol is the only approved PAH therapy shown to have a survival benefit in PAH. A few hands. B, she is not a candidate for lung transplant alone given her severe PAH and RV dysfunction and would require a combined heart-lung transplant. Not seeing too many hands there, maybe a couple. Her hemodynamics suggests she should be referred for an atrial septostomy in experienced hands. Maybe one. Although survival was not the primary endpoint in PAH clinical trials, the approved drugs improved 6-minute walk distance and improvements in 6-minute walk distance have been shown to associate with improved survival in PAH. All right, a lot of hands going up here. And E, a right heart cath is necessary in the evaluation of possible idiopathic PAH unless there's a good TR envelope with Doppler echo, in which case this would be okay because it would allow for the calculation of PA systolic pressure. All right, so the majority in this room picked D. Now again, I was going to have this question at the end of the talk, but that's okay. I believe the correct answer is not D. I actually believe the correct answer should be A. Okay? And I'm going to show you the data behind that, okay? That if you're going to pick a drug, IV epoprostenol may be the only drug shown to have a survival benefit. I can see that coming up on the exam. One point I do want to make on your answer choice D, and you can see how many words I put in D, okay? While 6-minute walk test was the endpoint in these trials, almost all of them, and while baseline 6-minute walk distance has actually been shown in some studies to be a predictor of poor outcomes, it's kind of surprising. The improvement in 6-minute walk distance on drugs does not correlate with survival. Okay? So that's why D would be incorrect. All right, so now let's dive into the talk itself. Now, by the way, one of the things I just want to mention is that this is a talk on pulmonary hypertension. There's going to be pulmonary hypertension on your boards. My main focus is going to be pulmonary arterial hypertension. And for those of you who don't understand why I'm not calling those the same thing, I think you will by the end of this talk. The questions on pulmonary hypertension that are not PAH, I think you're going to get a lot of those correct, either from this talk or in general. But the ones that can easily trip you up are going to be these PAH type ones, and they like to test on that. There'll be a few questions there. So let's dive right in. The hemodynamic definition of PAH. A mean PA pressure greater than or equal to 25 needs to be present for PH. Okay, I didn't say PAH, for pulmonary hypertension. If you want to define it hemodynamically, of course, you need to go a step further and show that on your right heart catheterization, you also have normal left-sided filling pressures. If you now meet criteria for pH and you have normal left-sided filling pressures, there's still the possibility now that this patient could have PAH, and we'll talk about the algorithm, how to get them there. Some organizations also require demonstration that the pulmonary vascular resistance is elevated to at least 3 Wood units, okay? So know the definition for pH, greater than or equal to 25, but remember, for PAH, if they gave you an LVEDP of 20 on the exam, I don't care how high the mean PA pressure is or how high the PVR is. If you want to say strict, those patients can never get enrolled in a PAH trial because they wouldn't meet criteria for PAH, okay? So the classification for pulmonary hypertension has undergone a few revisions, but the most common classification, or the most up-to-date, is shown here on this slide, which is really just a tweaking from a slide from 5 years prior put together at Dana Point in California. The take-home message here is not to necessarily memorize all the entities on the slide, but that the classification system divides pulmonary hypertension into 5 groups or categories. Okay? And so that's what really is important for you to know. So category or group 1, that is that group that we call pulmonary arterial hypertension. And under pulmonary arterial hypertension, of course, includes the idiopathic or primary varieties, but also includes some other associated conditions known to cause pulmonary arterial or pulmonary vascular disease. Remember, think about pulmonary arterial hypertension as there's a problem, the root cause is in the pulmonary vasculature itself. So in many instances, connective tissue diseases, notably scleroderma, can do this, uncorrected shunts, ASDs, PDAs that lead to Eisenmenger physiology, even some more esoteric conditions as well. So PAH is group 1. Group 2 is pulmonary hypertension due to left heart disease. Okay, everyone here in this room has seen this every single day in their practice. Left heart failure from any cause, valvular disease. I'll show you a couple slides on that. That would be group 2, PH, left heart disease. Group 3, lung disease. Okay, so they've got pulmonary hypertension and they've got pulmonary fibrosis. They've got PH from group 3, lung disease. Group 4 gets its own category, thromboembolic pulmonary hypertension, okay? And then group 5 is pulmonary hypertension, and no one is exactly sure where to put it. So it's sort of a wastebasket category of group 5. I wouldn't really be too worried about group 5 PH, okay? So very important, the most common cause of pulmonary hypertension is left heart disease. It's what you guys are doing every single day. HFpEF, HFrEF, valvular disease, it doesn't matter, okay? It's by far the most common cause of pulmonary hypertension. And there, you can get into sort of some of the interesting pathobiology and pathophysiology behind this, but at the simplest level, the reason why there's pulmonary hypertension in group 2 disease and left heart disease is simple. As the left atrial pressure goes up, the PA pressures go up, right? It's pretty simple, kind of has to go up. If it doesn't go up, how is blood going to get from the lungs to the left heart? So if the LVEDP is 25, of course the pressures in the lungs are going to be high. All right, so most common cause. And again, it doesn't necessarily mean we're going to try to treat the pulmonary hypertension directly. That's a different part of this talk. Most common cause of pulmonary hypertension, left heart disease, because the wedge is going up, the PA pressures are going up. In contrast to group 2 pulmonary hypertension, PH from left heart disease, the prevalence of PAH is actually rather uncommon. In fact, it's still considered an orphan disease. There are probably fewer than about 5,000 cases of PAH in this country. Okay? Yet it gets so much attention and so much notoriety, and there's a lot of reasons why. And I'm not saying it's inappropriate that it does, but still remember that although you're going to have questions on your boards on pulmonary arterial hypertension, it is rather uncommon. Probably somewhere between 2 to 10 in a million people with the disease. At the most simple level, the way to think about this is try to get away from thinking of pulmonary arterial hypertension as a problem of excess vasoconstriction. Yeah, there probably is some excess vasoconstriction, but it really, again, is, you could almost think about it more as a pulmonary vascular cancer, okay? You have an imbalance going on in the milieu there where the scales are being tipped to too much proliferation, hypertrophy, smooth muscle cell, endothelial cell, fibrosis, dysfunction, etc., as you can see here on the slide, and the balance gets tipped, and this starts to lead to pulmonary vascular disease. So for instance, you can imagine if you had sort of uncontrolled proliferation of endothelial cells and perhaps smooth muscle cell hypertrophy, this is what a pulmonary artery may look like on a histologic specimen. This is a patient who has severe intimal proliferation. The lumen should be significantly bigger than this. Try getting blood flow through this pulmonary artery. You can imagine the pressure in this artery is quite high. If you see the words plexiform lesions on your exam, you've got to think of pulmonary arterial hypertension because that is the pathognomonic histologic finding in idiopathic PAH. Okay, it doesn't have to be there, but if it's there, that's really specific to PAH, okay, to the exclusion of other forms of pulmonary hypertension. When I look at plexiform lesions, this one's not perfect, but they kind of look like a glomerulus, like a tuft of capillaries, uncontrolled proliferation. Just again, try to think of blood flow trying to get through that circuit. The pathways in PAH have been increasingly elucidated and are being shown to be more and more complex. This cartoon keeps it real simple, though, and for the boards, at a minimum, be aware of these three major pathways that are implicated because, frankly, most of the therapeutics that are currently approved try to target these pathways, and that is the endothelin pathway, i.e. too much endothelin, the nitric oxide pathway, either insufficient or it's not working very well, and the prostacyclin pathway, also diminished. And nitric oxide and prostacyclin try to help that vascular milieu stay dilated and non-hypertrophied and proliferated, and endothelin has some of the opposite effects. Okay, those would be sort of the three major pathways. I could see a question with a fourth choice on there, and of course the fourth one would not be the one probably. Okay, so how do we actually evaluate the patient with possible pulmonary hypertension? And so this is a schematic that has been published now about 5 to 10 years ago. And it actually does a pretty good job, not in that you have to actually go through all of these steps, and you don't even have to go through this sequence entirely. But I'm going to highlight some of the important aspects of this evaluation schematic. The first and arguably as important as any parts of it starts at the very beginning, right? Like most things, the key is to start with your history, your physical exam, and perhaps a couple of really inexpensive, readily available tests like an electrocardiogram. And the reason being is because how do patients with pulmonary hypertension present? They present with shortness of breath. And I told you that PAH is an orphan disease. So of course, if we were going through this whole algorithm with everyone you saw in your office with shortness of breath, I think we'd be in real big trouble in terms of healthcare dollars and economy. So what you really have to do at the outset, of course, is try to figure out what is your index of suspicion that this patient really does have pulmonary hypertension. And after talking to the patient, examining them, and looking for some findings of high PA pressures and right heart strain, you may determine already, you know what the diagnosis is, you're going down a different pathway, and that's appropriate. But if after seeing the patient in the office, you say, you know, I do think this patient may have pulmonary hypertension, they may even have pulmonary arterial hypertension, this gives you sort of a framework within which to kind of go through the algorithm. Now remember that original classification slide of 1 through 5 I showed you? Can I tell you the best part of that classification scheme? It's actually to help guide your workup. Okay? Even though, as I will show you, the drugs are approved specifically on the basis of that classification scheme, the most helpful to me is actually using it as you're doing your workup. Okay, group 2 left heart disease, group 3, okay, PFTs maybe, a CT scan, let's make sure they don't have lung disease caused or PH, okay? Go through that schematic to help you, and that's basically what this does here too, okay? I also want to point out that after you go through the workup, the diagnostic eval, at the very end, even though you might do this up front, but if you haven't done it right away, it will end here saying you've got to do a heart cath. I'm going to get back to this, okay? But I think that's a very important point. I think one of the questions that I said, and almost none of you answered, was, but we had a good Doppler echo of the PA pressure, so maybe that's sufficient. For the boards, and I'd like to think for real-life medical practice, that's not right. The other thing to keep in mind, and this is what makes it so tricky, I of course reminded you, as you know, that PAH in general is a pretty uncommon entity. But the problem is that patients are struggling who actually have it because they're not being diagnosed rapidly. This is just one study from about 30 years ago. This has since been repeated in multiple registries, and the data are similar. The average time from the onset of first symptoms until PAH is actually diagnosed is approximately 2 years, okay? So patients are dyspneic for quite a long time. You can imagine they're told a multitude of things. They've got asthma, try the inhaler, you're gaining weight, sleep apnea, maybe something else, okay? And patients aren't being diagnosed on time. So even though it's relatively uncommon because it's such a serious condition, we of course have to think about it and understand sort of the algorithm with which to go down to make the diagnosis. So again, I mentioned you take your history, you may do some simple things. What if you saw this EKG in the question stem, of course you'd be highly suspicious. The EKG does not have 100% sensitivity, but I'll tell you, in idiopathic PAH, it's probably in the 80-some% to show a right axis deviation and right ventricular hypertrophy, as you can see here on the EKG, even a right heart strain pattern perhaps, okay? So this obviously would give you a big clue that this patient may have PAH. The echocardiogram, which you're going to get pretty early. Again, occasionally I actually will look at the Doppler signal on the TR velocity acquisition to see what the estimated PA pressures is, but it's one of the last things I look at. One of the first things, of course, I'm going to do is look at this. What does the RV look like? Is the RV under strain and pressure? Again, if you got an echo like this, you'd be very worried of high PA pressures because this RV is strained. You oftentimes will see severe tricuspid regurgitation, okay? So an echocardiogram, the point here is it, of course, remains an indispensable tool. In fact, you're getting the echo not only to help you maybe make the diagnosis of pulmonary arterial hypertension, but just PH in general, right? Left heart disease. Is there LV systolic dysfunction? Is there diastolic dysfunction? Is there valvular disease? Maybe there's pericardial disease, okay? Maybe there's a congenital defect that you can pick up. So many things that are helpful from the echo that actually aren't specific to truly measuring the PA pressures, which is why echo remains really, really important in the early phases of the evaluation. Just to make this point here, that Doppler echo is simply too unreliable to be used to diagnose or follow pulmonary hypertension. I just showed two figures from two studies that were published at almost the same time, one from a group at Hopkins, one actually from our group, and we did this very similarly. The group from Hopkins measured PA pressures by echo and right heart cath within 1 hour of each other. Our group actually chose to do them simultaneously, but the methods were pretty similar. And what was also very interesting in the end, by the way, these are Bland-Altman plots for those of you unfamiliar with them. And the important points are not the minutia in the slide. It's two things. Number one, echo Doppler measurements of PA pressures actually do correlate, and I say the word correlate, with invasive PA pressure measurements. But just also remember what correlation is all about. If there are actually two modalities that were designed to test the same thing, the absence of correlation would mean that one of those is so terrible, okay? Think about if you said your ruler is the best and I said my ruler is the best and we measured things. Well, our rulers are going to measure tall things and short things, and they're going to correlate really well, even though they may not be truly in agreement, okay? And what these studies showed that while higher PA pressures by echo correlated with higher PA pressures with cath, the precision by which Doppler echo can do it was off a lot. Sometimes you see the limits of agreement as much as 40 millimeters of mercury, okay? So that's the limitation really with Doppler echo. I show this slide because as part of the diagnostic workup, as you're going through, you may say, well, hey, what about that group 4? How do I rule out chronic thromboembolic pulmonary hypertension? So one of the ways might be to get a CAT scan, in this case a CT angio. I like getting a CAT scan with contrast as part of my workup for two reasons. Number one, to see if I find clot. The other reason, particularly if it's a high-resolution scan, I really want to see if there's parenchymal lung disease. That's another big part of causes of pulmonary hypertension. And in fact, this is arguably the only curable form of pulmonary hypertension, which is if they actually have CTEPH and it's deemed operable. This is actually a combination of clot and endothelium pulled out from a patient who had chronic thromboembolic pulmonary hypertension. So the treatment of CTEPH is a pulmonary thromboendarterectomy. In the absence of operable suitability, of course, you could treat these patients with medicines. There's one drug that's actually FDA approved for this indication. But the bottom line is that if you can actually operate on these patients, you'll cure them. The other very important point to keep in mind for the boards, if you are confronted with a question that says, okay, are you going to get the CT with contrast or are you going to get a VQ scan? Pick the VQ scan, okay? And the reason being is that even though our high-resolution CT scanners have gotten so good at even getting to sort of sub-segmental levels, the truth is that sometimes you can actually miss clot, and they actually have very distal disease, okay? So I don't consider my workup complete without a VQ scan, even if my CT angio does not show clot, okay? So if they ask you that, I would pick VQ scan on the boards, okay? But understandable to get a CT with contrast also to look not only for clot, but for lung disease. And you're gonna get, and the VQ scan is positive, you're gonna get the CT scan with contrast because, you know, or a pulmonary angiogram so the surgeon can determine if they're a surgical candidate. Okay, so if we go back to the evaluation, that algorithm for how to work up patients. As you can see here, we start at the top. You probably got an echo. You probably then worked your way down through the algorithm, again, in no exact order, kind of checking your boxes. And then we get down to the very bottom, which says the right heart cath, okay? This is straight out of the guidelines. And it sort of talks about why you would want to get a right heart catheterization in these patients. I highlight that and then include this second schematic, not again for you to really see so well right now. I do want you to have it in your syllabus. I want you to be able to look at it and compare it because at a more recent update in the guidelines, this algorithm emerged. I can assure you that this algorithm and the one I was just showing you are nearly the same, okay? You will do fine with either one. But what I actually thought was important to highlight is two things that have emerged here. Well, one that has emerged, and number one is referral to a PH expert center. That was not actually in the previous guidelines. So if you have a patient with severe pulmonary hypertension and RV dysfunction, you should probably give strong consideration to sending patients to a PH Center of Excellence. But the other thing I wanted to highlight here is that this revised, if you will, version of the guidelines once again places a very strong emphasis on the need to get a right heart cath before determining not only the diagnosis, but also your treatment strategy. So let's dive into this for a second. Why is the cath again so important? Well, remember a few things. Let's circle right back to that original diagnosis. First of all, if for nothing else, we need to make sure they don't have left heart disease. Okay, and so measuring a wedge pressure, or in my practice, the first cath, we usually will do a left heart and get a direct LV-EDP because we think it's that important, okay? You want to make sure this patient doesn't have an LV-EDP at 22 or something, okay? Because it may affect your management, and again, for the boards, if they gave you a stem with an LV-EDP of 22, I would highly doubt they're trying to get you down the PAH route. The other thing is I'll show you towards the end of my talk is to establish severity and prognosis. And then this part that I've got to bring up because I actually think it's going to be on the boards and because it's just really kind of going by the wayside, I think. We need to kind of remind people of this, is to test vasodilator therapy at the time of the cath, okay? An acute vasoreactivity challenge, all right? So the guidelines would support that prior to making a firm diagnosis of pulmonary hypertension, particularly pulmonary arterial hypertension, all those patients will at some point require a cardiac cath. So this notion of vasoreactivity testing, I don't know how many of these you've been involved with or how many you've done, but let me spend 2 or 3 slides on this, because again, I just think this is going to show up as one of your questions. So if you take the patient to the cath lab and you measure their hemodynamics and you do an acute vasoreactivity challenge, and I'll show you on subsequent slides what that means, you have one of 2 results that will be derived from that test, right? In one instance, they may be deemed a responder. This is very important because while the majority of patients will actually not meet criteria for response, in about 10% or so of patients, they will. And sort of Joe Rogers in his talk also sort of alluded to sort of you know it when you see it. And this is really the case here, although I'll give you a real definition that you'll use for your boards. But I'm telling you, you know it when you see it, okay? It's unbelievable when the PA pressures melt away from 110 systolic to 38 in a matter of 10 minutes. That happens very rarely, but when it does, you take note of that. All right? And so those patients go down a totally different pathway and would be candidates for high doses of calcium channel blockers. In the majority of patients who are non-responders, of course, you'd consider other therapies, and we'll talk about those. Now, depending on which hospital you work with or for, and your pharmacy, et cetera, the bottom line is there's no correct answer here in that any one of these 3 drugs, in theory, can be used for your acute vasoreactivity challenge for pulmonary arterial hypertension. Notice sodium nitroprusside is not on this list, which is a wonderful drug to use for drug testing in certain scenarios. In fact, right, in many scenarios with pulmonary hypertension, but those are usually the patients who have high systemic vascular resistance and a high wedge and LV dysfunction. You're using it because you're trying to determine other types of information. In fact, it can be argued giving a PAH patient nitroprusside may actually be dangerous, okay? Because these patients, what's their wedge? 8? And what's their blood pressure? 90, right? So if you actually gave them a very potent systemic arterial vasodilator, that may not be good for PAH, even though it may be your drug of choice in a question stem with left heart disease and pulmonary hypertension. But whether you use epoprostenol or adenosine or inhaled nitric oxide, any of these 3 are considered acceptable, okay, for pulmonary arterial hypertension vasoreactivity testing. Okay, I promised that I would tell you what the definition of a responder is, and this is it. I would absolutely memorize this definition for the boards. You need to see a fall in the mean PA pressure of at least 10 millimeters of mercury. It needs to fall to an absolute value, mean PA pressure of less than 40. And cardiac output cannot drop in the process. Ideally, cardiac output actually will go up in doing so, okay? Memorize that definition because I suspect there might be a question that tries to either get you to determine that they are a responder or not. Okay? That is the current definition. Whether in clinical practice that's how it should be defined or not, that's not important right now. Okay, so what are treatment options for this terrible disease? Well, I alluded to calcium channel blockers, and I'll just spend 1 slide on calcium channel blockers, I think. And that is that in the patients who are fortunate enough to be deemed responders in that vasoreactivity test, the reason why we prescribe high-dose calcium channel blockers, in part, is because of the graphic shown here. This was one of the landmark studies looking at survival in patients who got calcium channel blockers because they were responders versus any other therapy under the sun in those who were non-responders. As you can see from the graphic in the green, those in this cohort that got calcium channel blockers nearly had a normal survival, complete survival with one early case, outwards of 5 years, and many of these patients will go on 10, 15, 20, 25 years and so forth doing okay. On occasion, you can actually have waning of their calcium blocker response, but usually this is what you see. Look at the sort of ominous prognostic survival curve if you're not a responder. So the stakes are too high, from my view, to not spend the extra 10 or 15 minutes to see if you can identify a vasoreactivity responder in the cath lab, because that will actually change your management. But for everybody else who are not responders, we at least have to be broadly aware of the other therapeutic choices. In fact, incredibly, for an orphan disease, there are more than 10 drugs currently FDA approved for pulmonary arterial hypertension. I think the actual number is like 13 or something like that. And these are the major classes: ERAs, PD5 inhibitors, there's one guanylate cyclase stimulator, and then a whole host of prostacyclins given through different types of administrative routes, okay? So another thing to at least be aware of is that when we give these drugs, I think, again, we like to think that we're giving them when we're lowering PA pressures. But remember in that slide where I tried to at least give you that cartoonish framework for pathophysiology, and I said, let's get away from this notion that it's an excessively vasoconstrictive problem. Yes, there is a component of vasoconstriction, but what this is a plot of, and I just took all the many different drugs in the trials and showed the delta change in mean PA pressure from the beginning of the trials to the end of the trials. And as you can see here, there was on average about a 3 millimeter of mercury improvement in pulmonary pressures from start of the trial to the end of the trial. Just to remind you, this is normal down here, okay? So you might have taken them from 53 to 50 or something like that, and in other scenarios they get a more robust response. Hard to predict who will and who won't. But what I do want to make sure you know is that except for the most recent trials, the PAH drugs were not approved because of the ability to lower PA pressures. They were approved for the ability to improve 6-minute walk distance, okay? The more recent studies have tried to go away from that, have tried to use more of a morbidity and maybe even a component of mortality in their endpoints, okay? But most of the approved studies to date are on the basis of improvements in 6-minute walk test, okay? So if asked that question, don't say because they've been shown to reduce PA pressures and things like that. Make sure you know that it's a 6-minute walk distance improvement. This was the question that I showed you early on and tried to defend my answer with this slide. Intravenous epoprostenol. Again, on the test, if they try to get you to pick a drug that has shown to improve survival, pick this one, okay? However, I will say this was a study that did use historical controls as its matching comparator, okay? But as you can see from the slides here, in patients who got IV epoprostenol, it did appear to confer a significant survival advantage over historical controls receiving any other types of therapy, okay? So there are question writers that like to truly make the point that IV epoprostenol has a survival benefit. That might actually be true. I kind of actually think it is true, but it wasn't a classic randomized double-blind placebo-controlled trial, okay? So be aware of that. I also wanted you to have this in your syllabus, but I'm going to make this really simple for you. This is the treatment treatment options for patients with PAH that come from the Fifth World Symposium guidelines. A couple of points here. Oftentimes they'll say to use the functional classification to help guide which type of therapy you want to choose. That's fine, okay? Let's make it real simple. If they're a functional class 4, you're going right to the big guns, okay? You're going to go right to parenteral therapy with prostacyclins. One example would be IV epoprostenol. If they're a functional class 2, you are likely going to start with oral therapy. Okay? And by the way, they will never ask you, in my opinion, to pick one versus the other. There haven't been head-to-head trials, so don't even worry about it. Okay? You like Bosentan, you like sildenafil, that's fine. The guidelines will support you picking that. If they're a functional class 3, it's a bit of a judgment call, so they give you options to use everything. All right? If you think they're pretty sick, you can go right to the big guns. If you think you want to start with oral therapy or continue, that's fine too. Okay? So that's the basis of this. They're not going to say which is superior, Bosentan, or tadalafil or something like that. I also want to point your attention to the bottom of this bottom of this table, because I saw in some of your questions that you've already been submitting, some of you made reference to a trial that was done and published not too recently that actually looked at this concept of combination therapy up front. The most up-to-date iteration of guidelines, as you can see here, puts initial combination therapy down pretty low as a 2B recommendation. I don't think that it's contemporary quite enough to seep into your board exam for this go-round, but just in case, just be aware that they did recently conclude a trial that looked at essentially upfront therapy with an ERA plus a PDE5 inhibitor versus an ERA or a PDE5 alone. And again, the endpoint wasn't survival, but it did meet its primary endpoint of improvements in the combination arm, okay? So just be aware of that in case they test it. I think I just have a couple more slides, and then I'll try to finish up here with one final question. Now, what if these drugs don't work? So what are we supposed to do? So if there's an inadequate clinical response, again, the guidelines would say if you haven't done this already, you may try sequential combination therapy or adding some therapy to their existing regimen. But for most scenarios, you got to start thinking about lung transplant. Remember, these are young patients often, okay? And you want to start that evaluation pretty early. I'm glad that almost no one picked that heart-lung answer, because what's pretty amazing, except for rare circumstances, you put a new set of lungs into that patient, that RV, which looks terrible by echo, is usually going to do just fine with a mean PA pressure of 19 millimeters of mercury, okay? So often you don't need to do a combined heart-lung. It's sort of unrealistic these days anyways. Very few are done. I do need to point your attention, though, to this part of the algorithm that talks about balloon atrial septostomy. Okay? Why? Because again, like for some reason, like question writers love testing this kind of stuff. I am pretty sure you're going to have a question on atrial septostomy, so I had to include it here. All right? This is rarely done in this country, although it is done. It's done in countries that often don't have access to drugs. So, for example, Mexico City, they do this a lot, all right? But basically, it's a graded serial dilatation of the interatrial septum to basically create a right-to-left shunt. And so you might say, what are we doing here? So just to briefly explain to you the concept here, remember, in these patients who are in such low output states because they've got such profound right heart failure, we're doing anything we can to get blood to the left ventricle, right? Even deoxygenated blood. In fact, part of the kind of neat thing when it really works is that what happens is not only do you get blood from right to left, so that's step one, increase left-sided cardiac output. Number two, you actually decongest the right side by doing that. You're sort of offloading the RV. You can argue you've reduced wall stress by doing that as well. And then, assuming you have a responsive bone marrow, you should get a reactive polycythemia, because you are going to make these patients hypoxic, right? When you do that. But the oxygen carrying capacity overall, the combination of increased cardiac output plus a hemoglobin that may have gone up to 18, ends up making these patients often better off when done carefully, okay? And that's the rationale behind here. How are they going to test this? I will tell you right now how they're going to test this. They're going to give you a question, and they're going to try to get you to pick atrial septostomy, or at least know the contraindications. Please know two variables for the test. Okay, number one, if you have an oxygen saturation less than 90% to start with, too low. Okay, don't pick septostomy because you're going to make them really, really hypoxic. But if the sat's 94, you might still have a chance. The other is going to be a right atrial pressure greater than 20. Okay, just too much concern that the right atrial pressure is 24, 25. You can actually flood the left side and put them in pulmonary edema. It's happened, okay? So just remember those two variables, right atrial pressure at 20, an oxygen sat of 90, and then you may or may not choose atrial septostomy. Okay, and then my last slide before the question is the prognostic indicators in pulmonary hypertension. Just know it's all about the right ventricle. Okay, so whether it's by invasive measures, RA pressure and cardiac output, by echo, it's TAPSE or other types of indicators of RV function. Even laboratory assessments like BNP predict prognosis because of what it represents, which is RV wall stress. Remember this in the yellow. High PA pressures have never consistently been shown to be a predictor of outcomes, probably in part because not only are really high PA pressures bad, when they actually start to do poorly and and are getting close to dying, their PA pressures actually go down, right? Because their RV fails and they can't generate the pressures. So when you throw it into a model, high PA pressures are bad and then low PA pressures are bad, and it probably cancels itself out, okay? So high PA pressure is not a predictor. All right, so in summary, and if we have time, we could do one last question. PAH is a rare fatal disease. Early diagnosis is critical. Just remember, most pulmonary hypertension is not PAH. A right heart cath is required for this assessment. Multiple approved therapies exist for PAH, but remember that calcium channel blockers in high doses are reserved only for those who meet criteria for vasoreactivity, and know the contraindications for atrial septostomy. Sean, should we do one question or do we got to move on?
Maybe one.
Let's do one. Okay. Yes, good. Let's talk about that offline. But for the test, just know right atrial pressure and saturations, okay? All right, last question, we're going to move on here. A 32-year-old woman has progressive dyspnea on exertion for the last 6 months, and she's seeking a diagnosis. On exam, she's got JVD, diminished carotid upstrokes, an RV lift, a TR murmur. Her EKG reveals RVH. Her echo shows severe RV dilatation with reduced function, but a normal LV and no valve problems. The remainder of your evaluation is highly suggestive of pulmonary arterial hypertension. You guys are going to get this correct, I think, but you might not have gotten it at the beginning. You do a right heart cath, and this is what you show at baseline, all right? Take a look at these numbers. The RA 12, the mean PA was 55, the wedge was 10, cardiac output of 5. You do a nitric oxide challenge, okay? This is exactly what it's going to look like. The RA is 10. Hey, look what happened to the PA pressures. They went down to 82 over 32 with a mean of 44. The cardiac output actually went up to 6, okay? Wedge stayed the same. Blood pressure's okay, all right? So, you got that? Let's do the question. After the procedure, you meet with the patient and discuss next steps in management. Which of the following would be appropriate? How about a show of hands? A, you recommend starting high-dose amlodipine. Okay, just a couple of hands. You determine that her pulmonary vascular resistance is 15 Wood units and recommend putting her on pulmonary hypertension treatment. Here's what it is. The point here is make sure you know how to calculate a PVR. Her PVR is actually not 15 Wood units, okay, so don't pick B. C, you opt to treat her with an endothelin receptor antagonist, bosentan, but recommend LFT testing and counsel her about birth control. Few hands, maybe half the room. In addition to starting her on PAH therapy, you recommend genetic testing for the BMPR2 receptor mutation. Okay, a few hands there. The answer here is C, okay? You don't start high-dose amlodipine because she didn't quite meet the criteria for a responder, even though PA pressures came down. Her PVR wasn't 15. And as far as the genetics, yes, BMPR2 is the most common mutation in heritable PAH. But at the moment, you probably wouldn't be testing everybody for this, but you might get genetic counseling, especially if there's a family history. So in this case, there would be nothing wrong with starting an ERA, just like there would be nothing wrong with starting PDE5 inhibitors. But for the boards, you got to know to check LFTs and birth control. Let's stop there. Good luck. Thanks so much.